Good morning, everyone. My name is Kevin Corbett. I'm the CEO of the Healthcare Authority and also serve as the Secretary of Health and Mental Health here in the state. Thank you for being here today. And for those attending virtually, thank you as well. I certainly appreciate you taking the interest in learning more about our managed care program that we're unveiling here in Oklahoma and taking time out of your day to join us. Let me first also thank the MetroTech for the hospitality in hosting us today. We certainly appreciate it. Looks like a lot of things going on here at MetroTech, a lot of advancement as well. Before I begin today, I'd like to take a moment to remember this day 26 years ago when so many lives were lost and so many lives were changed forever by the bombing of the Murrah building. I know many of in this room probably remember that day very vividly. I certainly do. I was very close to that building in my office downtown at the time. But really, what really struck me is really what occurred after that and what's demonstrated to the world, which is the resilience of Oklahomans and the ability to come together and solve a problem. It certainly is something that the world has recognized, and now we're known for it by virtue of being viewed as the Oklahoma standard. So I hope you'll take a moment to share with me this remembrance. Thank you. As I mentioned, we are invoking a new program with regards to managed care. But before I get into that, I want to talk about another initiative that we're undertaking as well, and that's Medicaid expansion. As many of you know, last year, Oklahomans voted to expand the Medicaid population. Currently, our SoonerCare program covers children, pregnant women, elderly adults, and disabled individuals. Through expansion, the Healthcare Authority will now serve adults ages 19 to 64 whose income is 138% or less of the federal poverty level. Those adults will be eligible for SoonerCare to begin applying for SoonerCare June 1. I think that's a critical date for everyone to remember, June 1. Benefits for that population will begin July 1. This population, among others, will then transition to our new managed care program, SoonerSelect, which we're here today to talk about. Before I do, let me make some introductions. Part of our managed care program that we're unveiling includes the assistance of partners that we have selected, 7 to be exact, both health partners and dental partners. They're represented here today, and let me introduce them. First, Blue Cross and Blue Shield of Oklahoma, Oklahoma Complete Health, Humana Healthy Horizons, and United Healthcare. And our dental program, which is represented by DentaQuest, Liberty Dental, as well as MCNA Dental, are here. Along with my fellow colleagues from the Oklahoma Healthcare Authority, I'm also proud to introduce Commissioner of Mental Health and Substance Abuse Services, Carrie Slatton-Hodges, who's participating with us and has been an integral part of this program development. And let me take a personal privilege, if I might, to congratulate Commissioner Slatton-Hodges on her unanimous confirmation from the Senate last week. Let me give you an overview of today's program. We're going to go through an overview of the SoonerSelect program, which is our new managed care program. We'll then open it up for questions and answers. After that, everyone in the room will have the opportunity to visit with our partners from our health plans and our dental plans. They're here to answer any of your questions, provide information with regards to their services and their companies, and I hope you'll take the time to visit with them. So let me start with the basics of why we're here with SoonerSelect, and it really starts with one sobering statistic, and that is we are 46th in the country in terms of health outcomes for our citizens of Oklahoma. At the Healthcare Authority, we're certainly committed to improving health outcomes for our members, and this initiative will make a significant shift in being able to do that. A managed care organization or a managed care delivery system is just that, the management of care, the coordination of care. And as I mentioned, we have partnered with 7 organizations to help us administer the program at the Healthcare Authority. These companies are known as MCOs, they're known as managed care organizations, they're insurance companies, very similar to what you may be receiving from your employer and others. What is so unique about this group is they do provide whole person care to our members in obtaining needed medical, dental, and really critical behavioral health care. And they also help with referrals of social services, prevention and management of chronic disease. So if you're wondering who else does this, 40 other states do this around the country, have Medicaid programs that are based off of management of care philosophy and use others to assist them in that, and have seen better results with regards to quality improvement, access to care, cost predictability, and savings. So a little bit about our program. Participation in the new SoonerSelect program will be based on our members' current eligibility category and will be about 800,000 of our current membership that will transition to our SoonerSelect program. That's our pregnant women and children, our low-income parents, and our expansion population. One notable population that is not moving to the managed care program today is our adult, our age blind and disabled members. That is a group that is very fragile, and we've opted to wait and transition them at a later date. Also, our American Indian population that is part of our Medicaid program has the option to be in our program. They're not mandatory, where all others are mandatorily going to be moving to SoonerSelect. As I mentioned, Medicaid expansion application for eligibility begins June 1. Benefits begin to receive on July 1. The SoonerSelect program begins on October 1. Just critical on that. Certainly, this was not a decision made in haste. It was a very thoughtful conversation with the governor and others and diligence that went on. I think it's fair to say that the governor is very committed to improving health outcomes in Oklahoma. He looks to this move as one lever to do that. And I think his support for this initiative is unwavering. So for those that serve our Medicaid members, that's the provider group who are so critical, we recognize that your partnership is critical to our membership. And it's because of your dedication to serving this population and improving their health that we knew we couldn't make this transition without your input and without your guidance. And so back in July, we did seek input from all participants with regards to how we would structure this program. We received about 100 responses back. They were very lengthy. And we've taken all of those into consideration, and many of the recommendations you'll find in the design of our contracts and our program with our third-party partners. Continuing in that spirit in terms of seeking input, that's why we're holding this town hall. This is the 4th town hall we've held, and we'll hold more. The intent is to give you as much information as you need to understand how this will work for you as a provider or as a member. But also to seek input and guidance as well. We still have time to implement this program. That's what we're involved in today, and we look for your input and guidance on that. So allow me to introduce the team that will be here to answer the questions that you might have. And I'll start with Melody Anthony and have her introduce herself, and then we'll go down the row. But the point here is to take the opportunity today to answer any questions you may have, receive any input you might be interested in providing to us, and then give you the opportunity to visit with our plan partners after the meeting and take the opportunity to visit with them and get comfortable with their companies as well. So Melody, if I can ask you to go forward.
Sure. Good morning, everyone. Melody Anthony. I'm the State Medicaid Director and the Chief Operating Officer for the Healthcare Authority.
Good morning. I'm Trey Rains, Deputy State Medicaid Director at the Healthcare Authority.
And I'm Carrie Slatton-Hodges. I'm Commissioner of the Department of Mental Health and Substance Abuse Services.
Good morning. My name is Aaron Morris. I'm the Chief Financial Officer with the Healthcare Authority.
Good morning. I'm Dr. Nathan Valentine. I'm the Chief Quality Officer with the Healthcare Authority.
I'm Mike Herndon. I'm the Chief Medical Officer of the Healthcare Authority.
Good morning. I'm Karen Luce, the Director of Dental Services, Healthcare Authority.
And Terry Cothran, Pharmacy Director.
Okay, before we open up to questions, I'm going to have Melissa Ritchie, who's our Chief of Communications, come up here and kind of moderate the Q&A from both the folks in attendance here as well that are online. I'm going to ask Melody Anthony to go through and maybe give you some basic understanding of the features and provisions that we have in moving to our SoonerSelect program. Some of these questions are common questions that we've been asked at other town halls, thought it might be efficient to go through and maybe give you some understanding of those questions and the answers that we've provided so far today. So Melody.
Good morning again. I think it's very important that all of us who are trying to transition our healthcare delivery system in Oklahoma understand that the program that you have today, that we have today, that serves over 1 million members, we tried to mirror that as much as we could moving forward. with our new managed care partners. So what we basically did based off the input that Kevin was just referring to is we looked at our current program, then we wrote our RFP based off of what we wanted that program to look like moving forward. And we also did lessons learned from the 40 other states who have transitioned to managed care. We also did some technical assistance with our partners at CMS to make sure that our final product that hit the street was exactly what our providers and members needed. So if you will look at the slides that Melissa has been showing, it's, we pay claims every week. We want our managed care partners to pay claims every 14 days. They have a little bit more reporting requirements than we do, so 14 days fits back best into their delivery system. We have prior authorizations for behavioral health, medical, and dental. That continues. We have a provider network that is statewide. The managed care organizations need to be statewide. They have to prove adequate access for wherever our members live. So we have worked in concert with our plans to make sure that they have adequate access and adequate provider network. We've also made sure that the members will be given the opportunity to pick the plan that's the best match for their needs. Even though each plan is identical in basic requirements, they still have the ability through the flexibilities at the federal level to come up with some nuances that they can mirror each other or they can complement each other. So I just want to make sure that everyone understands that we do not take this transition lightly. Our partners are very committed. And I also want everyone to understand that if a member or a provider has any concerns with any issues that are happening through their new delivery system, that they do have the right to a grievance, they have the right to an appeal, and if the health plans cannot satisfy their issue to where they feel comfortable with the response, the healthcare authority is still responsible for everything that those members need. The one thing you have to remember is we are still the Medicaid program in Oklahoma. We will always be the Medicaid program in Oklahoma. These members are our members, and they will continue to be our members. We're just making sure that we are able to provide them everything they need, basically at the county level, at the town level, wherever those members live. We want to be able to meet them moving forward.
So I'll add just a little onto what Melody mentioned and kind of walk you through the member experience over the next few months, as well as the provider experience. As Kevin mentioned earlier, we'll start sending notices out to members at the beginning of July, letting them know that August 1st, they can sign into their MySoonerCare.org account and choose from one of the 4 medical plans or one of the 3 dental plans. We'll give them a member services contact information so that they can call our member services hotline and receive choice counseling. We're currently in the process of ramping up our member services education with our current staff, as well as our contracted member services call center staff, so that they are apprised as to all the benefits that Mel mentioned that are value added benefits that are in addition to the current services that we deliver through the Healthcare Authority. So at that time, we'll expect to have pretty adequate networks from our plan. So a member can call in and say, please describe to me the difference between Blue Cross Blue Shield and Humana, for example. And they can say, my doctor is Joe Smith. Can I pick a plan where Dr. Smith is still in the network? And so we'll guide them through that process. Members will have between August 1st and September the 10th to make that choice. At that point, if they have yet to make a choice, they just didn't open their letter or just didn't call in, we will auto assign them to a plan using a very basic round robin algorithm, assigning to each available plan until every eligible member has been allocated. From that point, you're still not locked in. So now you're going to get a letter saying you've been assigned to Oklahoma Complete Health, for example. If I open my letter and say I would rather be with Blue Cross Blue Shield, you have 90 days to call or log into your MySoonerCare.org account and make that change within there. And so you'll be aligned with that plan. Once that 90 days is passed, though, the member will be locked in with that plan until the next open enrollment period, which steady state open enrollment will always be May 1st of every year. That's going to get us on a state fiscal year plan year. So the new plan years will start July 1st. From a provider perspective, my guess is that most of the providers watching or attending live today have probably gotten welcome packets or contracts from some of our partners in the room. They are in the process of setting up their networks. And so, it takes time to build a network. And we would say too, we would encourage all of our providers to go ahead and start having those conversations with the plans, talking about reimbursement, talking about what does billing look like in your portal, for example, because we recognize instead of going through either your EDI vendor or directly through the provider portal currently, you'll be working through plan portals at this point. So we don't really want folks to wait until early to even mid to late September, knowing we have an October 1st date, because it's really going to take some time for you to get trained on new processes. And we want you to have adequate time to receive that training and really be prepared for an October 1 start date. So speaking of reimbursement, I know that's big on everyone's mind. We will say that we try to give the plans as much flexibility as possible to provide their service delivery model and really leverage their experience from other markets and their commercial markets. So we did set floors for certain reimbursement for providers. For example, behavioral health. We recognize that the behavioral health system has traditionally been fairly unfunded compared to other medical systems and compared to other states. So it was important to us and Commissioner Slatton-Hodges that we not go below at least what we reimburse now as a state Medicaid agency. So we established a floor for those services. Also, federally qualified health center services, rural health centers, certified community behavioral health clinics. For example, most of our safety net clinics that really take care of a lot of our uninsured individuals, we wanted to make sure that those floors were set. In addition, Kevin mentioned that our American Indian, Alaska Native population do have the option to opt in to the managed care delivery system. If they do, we will still pay our tribal partners their encounter rate, which we're able to get 100% federal match on. And so that process will still continue. We're working on processes for purchase and referred care through tribal systems as well, so we can make sure that we're maintaining all of the federal funding that we have available to us now. Mel mentioned too, not just handing over the keys to all of our new partners, but this really is a partnership. In fact, and it's really, we at the Healthcare Authority are switching our mindset from a direct service delivery system, for example, to really monitoring and oversight. And so we have volumes and volumes of reports that all of our partners will have to submit either weekly or monthly, annually, so we can make sure they're providing services or prior authorizing services timely, for example, making sure that their call center metrics are where they should be so that our providers and members are not sitting on hold a lot with them, making sure that their claims get paid on time. We did require in the contract that plans have 14 days to process a clean claim, and we expect them to do that at least 90% of the time, or we will assess financial penalties. We've had, most of our plans have committed to paying quicker than that, but that's where we wanted to set the minimum. Federal law actually allows us to pay 45 days, but we learned last time we did managed care that 45 days is way too long to go in between payments, especially with our provider network.
Okay, thanks for that introduction. Melissa, we'll have you come up and you can facilitate questions. I'm going to join the panel to participate in the Q&A.
Thank you, Secretary. Can you hear me? Okay. Thank you, Secretary Corbett. We will now open the floor to questions for our panelists. Please raise your hand if you have a question. For those of you joining us virtually, please submit your question in the Q&A section in the meeting, and we will ask our appropriate panelists to answer, or one of our online monitors will answer for you. So we will go ahead and open the floor now to questions.
Good morning. Can you hear me okay? Okay. I have to say that I wish I was not here. I'm an occupational therapist, and I'd rather be treating children than talking to you guys, but that's my job right now because I care deeply about the children that I serve. Like I said, I'm a pediatric occupational therapist, and I'm an owner of a therapy practice for occupational, speech, and physical therapy. I've been a pediatric therapist for 25 years, and my practice has been serving children with Medicaid for 18 years. And we have been committed to health outcomes from day one. We currently provide OT, PT, and speech to over 125 Medicaid families. I have to say that our pediatricians are very good at screening infants and toddlers, and we are seeing children now younger and younger compared to even 10 years ago. I respectively disagree that MCOs are going to get children referred to us sooner because this is already happening. We are getting referrals for infants and toddlers. I have 30 on my wait list today and will be expanding so that I can serve these children next month. The problem I see in MCOs is what happens once we have the referral. We now have 4 different agencies to deal with and 4 different authorization systems instead of 1. We have had no reassurance that these private for-profit entities will respect our clinical judgment to reimburse us for the recommended visits and recommended time that we request to see the child. Here's a typical case for us. Gabe, who's on the autism spectrum, was kicked out of daycare because he was biting other kids and has explosive meltdowns due to his sensory defensiveness. I will not be able to sleep at night if I have to tell Gabe's mom that I can only see him for 30 minutes every other week due to the new structure of value-based insurance reimbursement. This child needs to be seen for 2 times a week in the beginning for an hour each session because of the type of intervention that we provide, the parent modeling that we do, the parent training that we do, and because it takes time to transition this child in a therapeutic manner from his car to our play space. We help children with special needs be able to trust the world and be able to leave the comfort of their own home and become valued citizens of the community. This is the value in our preventative care therapy. And we are already managed by OHCA to produce these outcomes, or we get denied authorization. We help the mom be able to return to her job because her son can now return to daycare. This is a valuable outcome. It is often difficult to put a number on this outcome for our pediatric patients. My concern is about the performance ratings you have mentioned in previous town halls. I have been at all of them. It is much easier to put an outcome on an adult with a knee replacement. You can measure the range of motion. It is very different for our population with children with special needs. If providers' performance ratings in our field are based on how quickly we discharge patients, then that will lead to less providers willing to see patients with severe disabilities. My first question is about how this performance rating system will be conducted, who will be doing it, and how will we be rated as therapy providers? I'll ask my second question after I hear from you on this one.
Okay. Again, is this on?
Yeah.
Thanks. I'm Mike Kern. I'm Chief Medical Officer in Therapy Services. Prior authorization lives in my shop, and my shop will continue to do the monitoring for appropriateness of therapy services, PTOT speech. One of the 130 some odd reports that we will be requiring of these plans is indeed a approval rate, denial rate of services. So we will be monitoring that. We will continue to have a licensed Oklahoma occupational therapist, physical therapist, and speech therapist contracted with us. They will be part of that oversight team. So although I value your concerns, I don't know that I can share that I have the same concerns at this point. Our plans are committed to giving children the best services. Part of the reason we're making this change is to enhance the value, and of the services that children get. So I promise you that we will be doing our due diligence to make sure that our children and our children together get the services they need.
Can you touch upon the provider rating, the performance rating that you have mentioned in the previous town halls? Because that has not, it said year one, kind of like that's not going to happen, but year 2 and 3, that the MCOs will creatively be allowed to do performance ratings. I'd like to have that addressed.
I'll let Dr. Valentine talk here in a second, but so we do have quality withholds built into the contracts that these plans have to meet in order to get the full reimbursement. So the first year, there's some, it's not a real robust withhold because the fact is we need to get these plans up and operational, but those will be monitored on a yearly basis, and there will be withholds. Performance of the plans will be on the website. As I'm told, Mel can address that further maybe, but so there will be withholds and there will be information, public information on the website. Do you want to talk about the quality and the rankings? No.
One other element that we're going to have, can you guys hear me okay?
Mhm.
I can't tell. Is the rating of providers, kind of side by side providers, how their outcomes or how the process measures of their outcomes are doing, how they're performing compared to their peers. That does take a process to develop, and there will be stakeholder meetings, and the conversation will continue quite a bit before we actually come to those ratings. So there's more. I look forward to continued conversation on that front, but it's not laid out yet in detail. We just plan to make sure that we're transparent in the quality that our providers are offering our members, so that we can continue to move toward the favorable outcomes that we need for our members.
What I would say too, just in listening to you, and first of all, thank you for coming today. We know you'd rather be seeing patients, but your voice is valuable at this table, and we're glad you're here. I heard several quality outcome measures just in hearing you speak earlier. Mom's able to maintain employment. Kiddo is doing better in school, if I had to guess. He's able to maintain in classrooms and home setting. Makes mom's life easier probably with other kids if kiddo's not acting out at home. Those are all very great outcomes that I would guess would go into how we rate our providers and our plans. It's not going to be strictly utilization based or how quickly we can get kids in and out of treatment. That's not our philosophy now. And it's not the philosophy we're going to impart on our plan, our partners. I will say too, just in speaking with our partners, there is a profit element, of course, but I would say philosophically, it doesn't make sense for them to quickly get in kids and any member in and out of treatment because we know that's not where the treatment ends, right? They'll escalate in a classroom or another setting, and they'll be in a crisis center, for example, or we'll be working with mental health needs in an ER probably. And so those are all costs that will be borne by the medical plans, and they don't end up saving money that way. We would rather them be served in your setting. And I understand you have a great relationship with your pediatricians. We have to remember we have a statewide service delivery system where that's not always the case. So our hope is through our health risk screenings that all of our members are going to go through as they enter the plan and become members of plans. We're really on a statewide level going to be able to identify a lot of these medical conditions, behavioral health conditions a lot earlier and get them into your doors to be seen even earlier than they are now for those areas of the state that don't have those great partnerships with pediatric specialists and providers as yourself.
Thank you. My second question also relates to Gabe's family, the child who has autism, because in other states, we've been polling other therapy providers in other states, and in Texas, pediatric therapy providers have decreased considerably. They don't take Medicaid because they can't afford to take Medicaid anymore. So this is a very close neighboring state that we're basing our concerns on. So my question is, for a child like him, he's being denied services from an MCO. He has autism, and we can't produce the outcomes because we are not being allowed to see him frequently enough. So can you this where I'm going, Aaron? Can you guarantee that when I request 12 months of services for twice a week, because I know from my 25 years of experience, this is what this kid needs, and I'll titrate those services down, can you guarantee that they will respect my clinical judgment? Or will they be given the liberty to cut down for cost savings to 4 months?
So I will say we're better than Texas, of course, in all ways possible. But I will say too that, you know, like us, our plans will, you know, take medical judgment and your clinical expertise into account when authorizing services. But also going through a medical review at their level, just like with us now. I'm sure that there's been instances where Dr. Herndon's folks haven't approved requests that have been coming through currently. I know that's true with all level of services that we approve. Having said that, though, there's going to be appeal rights. There's going to be doc-to-doc availability, so you can talk to other clinicians and really talk it through, who are, you know, so you can make sure everyone's on the same page, just like it is currently. So there's no way I could tell everyone in the room that all their level of services will be exactly the same and will get exactly what you're asking for, because that's not true today. But I will tell you that we're going to be watching it closely, and if we see huge spikes and declinations for prior authorizations or a really strict medical necessity criteria come through, which is something that we will approve prior to it being implemented, that will definitely be on top of that.
I just know from previous times when we had Evacor per se, and the appeal process was, the administration time skyrocketed when we had to do an appeal. And yes, we were able to talk to another practitioner in another state to try to make the claim, but the administration costs, you know, were overbearing. The therapists were, you know, literally crying in my office, just like, you know, I've already told them, you know, over and over, and we're having to do paperwork every 6 weeks instead of every 6 months. I mean, these are children with long-term disabilities. And I just want to make sure that on your advisory board, there is someone there with pediatric experience, because we are a very special niche of providers. It's very different working with children than it is with adults doing rehab. And I have spoken to OHCA administration before, and they've said often that the rules are based on rehab, not on pediatrics. And I just am hoping that there will be someone at the table who has pediatric experience. Thank you.
Sure, I would encourage you to talk, you know, after we're over, stop by and talk to the medical plans because they're each required to have advisory boards of their own with certain specialists, representative of the majority of our provider population. And so I agree, your voice would be very important to each of those plans in that capacity.
This is my last question. I'm sorry I'm hogging the table here, but how do the MCOs plan to add value to Oklahoma Medicaid system without cutting valuable services?
So we are in the process now of creating a benefit comparison guide that should be published fairly quickly. If I had to guess, probably in a month or so, where it shows all the base benefits and then how, you know, and what exactly their value adds would be. I did hear you mention earlier preventive services, which is currently not something we're allowed as a Medicaid agency to really reimburse for. It's more treatment focused. And so my guess is you've probably had some services decline that are more educational in nature or prevention focused. That would be something that the plans could offer, you know, and talking through them as a value-added benefit specifically for your field.
I have a question virtually for Commissioner Slayton Hodges. How will managed care benefit the behavioral health population?
Well, I think it's interesting, and I'm assuming this is on, that in reality that we still say kind of the behavioral health population, because one of the things that I hope we're able to do moving forward with the plans is, and I know in our how we wrote the RFP, the important things that we felt like needed to be in there is that while we do a great job in Oklahoma of treating people with serious mental illness, chronic addiction disorders, what we have struggled with over time is making sure that everybody, when they are involved with their physical care provider or any provider they engage with, that they are being asked questions about whether they are experiencing distress in terms of anxiety, depression, et cetera, so that we can start to get the care to those folks at the very earliest point in time, and that we can start integrating that better into the physical care that we do across our state. And I think that is where we have the greatest opportunity to go from a state that has very high rates of severe mental illness, very high rates of addiction, is if we're able to start meeting people every time they walk into any physician or medical care office, is to start asking those questions, start providing what kind of care they need at that point in time. And if it is warranted, then making those smooth referrals over to a more specialized treatment provider. And I feel like as a state, we have a long way to go there, but we have written some very specific things into the RFP for the plans to greatly broaden that those screenings and that identification will take place at an earlier point in time, so people can receive identification and treatment much earlier in the course of these diseases.
Commissioner Slatton-Hodges, I have one more question for you. Several behavioral agencies are small and do not bill private insurance, only Medicaid. So will there be a workshop to help providers?
Absolutely. And in fact, the amount of training and technical assistance, number one, that is built in as a requirement of what plans will do, but is also also a normal course of action, because the plans want and need persons to provide care, and they also want and need persons to know how to get enrolled, get credentialed, et cetera, to get that care out there. So there will be not only workshops, but the same way you can call now to get assistance from the healthcare authority, folks will be able to come out. Even if you're having specific problems about walk me through this, you will be able to get that technical assistance.
Hi, can somebody address the pharmacy side of this and prescription coverage, reimbursement? And if somebody is stable on, say, a rather expensive antipsychotic injection, will we have to start all over on prior authorizations, or will they roll right over and be covered?
Yeah, the pharmacy section will mirror, the plans will mirror ours currently. So reimbursement will be the same. The prior auths that are already in place will get transitioned over, so there won't have a need to redo those. And the formulary that they follow, it'll be referred to as a preferred drug list, but it will be the same criteria that we have today. So you shouldn't see a change in what you're doing today versus in the future.
Hi, I'm Diana Persen. I'm also a pediatric occupational therapist, and I practiced for over 35 years. For the last 13, I've owned my own clinic as a Native American sole owner, and I practice in Edmond. The upcoming proposed changes for Medicaid healthcare services has me extremely worried, as over the last years, there's been budget cuts, loss of income due to the current pandemic, and now therapy assistant reimbursements has also been cut. Changing from an MCO model will significantly impact me and many of my other small business owners that sit around me today. We provide services to children and young adults of various ages and diagnoses. Many of them have life-threatening conditions such as failure to thrive, feeding dysfunction, food aversions, inability to express or understand language, poor social skills, lack of self-help skills, sensory dysfunction, motor impairments, and medical challenges, all which require timely services and skilled intervention. We as clinicians interact with families and children more often than many other professionals do. We assist our families and children in so many areas that are not billable currently or reimbursable, because advocacy is the right thing to do. Many of us treat from our heart and really enjoy and help out our families daily. We value our patients and assist them, and many of us provide equipment, resources, collaborate with other agencies without being able to be billed or reimbursed for any of that time or supplies handed out. These changes discussed to switch to an MCO will impact our bottom dollar and the survival of keeping our doors open, which brings us here asking many questions. We all want to know what we can do to best serve the families in our community. Some of the children, as I mentioned before, have significant medical needs, from kids on being on the verge of needing a tube feeding as lack of food aversions, to also needing surgery, for also being in the first percentile for weight and height. As you can hear, I do a lot of feeding services and oral motor intervention. As a mother who has also had a premature child, the strong desire to be able to feed and nurture your child is so innate that when you need help, you need help. Therefore, I want to talk about the prior authorization component. It is vital that we take the time as skilled professionals to treat and prevent the worst outcomes. It is also an investment that research shows and pays off with much better health outcomes from early intervention than from waiting for repeat hospitalizations later on. This brings us here also asking the questions that so we can continue to provide services. I have 4 questions for you. Getting started in therapy can take so long, sometimes even up to 6 weeks. Many families are asked to go to the doctor. They express their concern. Then the clinic gets a referral. Then we send an approval or a request to Oklahoma Healthcare Authority. Then after the request is approved, the clinic can then talk to the family and get the family scheduled. Again, sometimes it takes as long as 6 weeks. Many of this is due to not getting all the pieces of paper that we need for just getting the mother, can I treat this child and help out this family. When you're a parent waiting for help, this feels like an eternity. Many of our new families frequently call the clinic and ask, why is it taking so long? What can you do? Don't you know that my child needs help? Will this prior authorization process remain the same? Will it be shortened? And how can it help improve the outcomes?
Again, thank you for your comments. I'll start by saying, I know there's just a lot of generalized fear in moving in this direction, probably based on, like you said, our partners are state to the south and other states. So I'll start by saying there's something advantageous about being 41st in the nation to do this, is because we can see the mistakes and successes that every other state has come across and as they've gone through that process. Because of that, we were able to look at other states, say, okay, this is important, that's important. One thing that's very important is timeliness of PAs, of course. We have actually, in most cases, set more of a strict timeline standard for PA approval than we even have on ourselves today with our partners. I will say too that you mentioned advocacy several times. Folks coming into this program will have a designated care coordinator who can be that advocate for the family. So the family can call and talk to, and they'll reach out to them, and will be ranked based on health needs as to how much contact they get from that care coordinator at the plan level. So they can be that person saying, let me follow up on this, let me follow up on that. I'll also say that there's a lot of more technical requirements on our partners in terms of interoperability of data than we're able to access now, since we still don't have a statewide electronic health or health information exchange. Plans will have that capability within their networks, and so we expect a quicker exchange of data so that it doesn't hopefully take as long as it's taking today as we transition to this program. Dr.
And just like we have currently, any urgent need can be communicated to us. There is a direct email line to Oklahoma Healthcare Authority that is monitored. So phone calls, I mean, I know that our staff take a lot of these phone calls for urgent needs. So if a child like you described, if there's an urgent need, the plans will be required to have an urgent line so those can be addressed timely, just like we have now.
Well, I appreciate that comment. The email address that we get and the phone numbers that we get to express our timely concerns sometimes take 48 hours or more to get a response. Then when we do get a response, it is, okay, we've heard your complaint or your concern. We'll get back to you. So again, I am stuck in the middle of helping the family that needs help and waiting on an immediate response. Unfortunately, it hasn't been working for us. As you see, my colleagues around me are also shaking their head that they do not get the same response that you're hoping that we get. Unfortunately, we don't.
Happy to visit with you after this further to take back to my unit what I need to take back. So
That sounds wonderful. My second question is, as a skilled professional, this has kind of been addressed a little bit by Jody, who just spoke earlier. My knowledge to use that I've used to assess and draw conclusions and write detailed evaluation and to describe the needs and the concerns to develop a plan of action takes several billable, non-billable hours. We get 1 hour from Oklahoma Healthcare Authority to draw these conclusions. Many times it takes the first 15 minutes just to get the child settled in the room, not even including the time that we spent on the phone talking to the parents before we even see them. If we don't invest our non-billable time, then we don't get the justification that we need, and we don't get the plan of approval that we want to proceed further with healthcare. So again, will there be limitations placed on frequency and duration of treatments? You mentioned a little bit about that, but I also am curious of how many months of therapy will get approved, or if there's going to be a standard that it's based on just what's been submitted.
well, first of all, medical necessity will drive decisions. And if plans are not approving medically necessary services, they will be held accountable for that. So as far as the duration of an approval, I don't anticipate that changing. Our therapists now make determinations based upon what the anticipated length of need is, and the plans will be held to that same standard. And can I just, one comment I forgot to you made earlier. It is important to us that providers are part of the treatment of the child. There is a requirement that providers do make referrals for therapy services. I can give you lots of examples, but we have been contacted in years past by parents who did not even know their children were in therapy. Okay, I mean, that happens, mostly in daycare settings and things like that. So we've talked to providers who said, I did not know my patient was in therapy. So we made some changes a few years back, as you and your colleagues probably know, that required both that the parent be engaged in the child's course of therapy and that the provider be a part of the decision-making for therapy. So there is a reason for that, and it's team-based care. I mean, the parent should be engaged in participating in that child's care. The primary care provider should be engaged in that child's care. So it's not to put more restrictions, it's to improve the experience and the outcome for that child.
I appreciate that. In prior town hall meetings, it's been stated that families can change from one MCO to another. I believe I heard mentioned before that there would be a 90 days into one MCO before you could switch. As a clinic, we spend hours trying to get services authorized for a specific given period of time. But during that time frame, a child could become or can switch from becoming eligible to non-eligible. What will be the procedure for the current prior authorization policy to be transferred from one MCO to another? And how will we go about knowing that children are still in effect or eligible?
So I'll mention first of all, as they transition from the healthcare authority to the plan are required by the contract to recognize those PAs for 90 days. So that's the PA 90 days. Then we also have the 90 days within which you can change a plan. And so that's from the original date that it's selected or assigned to you, have those 90 days. We're currently working through part of our readiness process is we have 11 work groups with OHCA staff from the commissioner's staff, as well as individuals from all the plans working through how this will look not on paper on a contract, but how it'll look in real life. And so we're talking through plan-to-plan transactions. Plans have indicated they'll recognize existing prior authorizations as they go from one plan to the other. We're working on what that information exchange looks like, how a plan will communicate to the next plan, how we'll inform a plan that someone has left and that they've come on to yours. So we want to make that as seamless as possible, but any feedback from the provider community that we can get to help in that, create that, because we're right in the throes of that at this point, would be super helpful.
I guess my response to that is hopefully our offices will not have to be checking all four companies to see if one family has made a switch. Like there needs to be a system in place where we get notified if families are changing, hopefully prior to the date of change, as if we complete a service on Wednesday and they changed on Monday, our Wednesday services will not be reimbursed as per my past experience. So I have one more question. As we mentioned before, the continuity of care is very important. During the prior authorization, again, eligibility can change, but I also want to look at, is there a way that we as clinicians can know ahead of time if there's one company that's going to service therapy differently from other companies, or it will be the same across the board?
So I'll say as far as prior authorization requirements, medical necessity criteria, units allowed, that kind of stuff, they're required to be no more restrictive than we currently are today. And so, but in talking about additional flexibilities, how their processes work, value addeds in that arena, I would strongly encourage you to talk to the folks at the table after the meeting, just to ask them what they're, when they reach out with a contract, call them, ask them those questions, because they're all going to be just maybe a little different.
Hi.
Hi.
My name is Stacy Taylor, and I also am a pediatric therapist. I'm a physical therapist, and I just want to thank you for your time, for being here today, and for listening to us. One of my main concerns is I serve mostly profoundly disabled children, so my peer-to-peer ratings probably aren't going to be as efficient looking as compared to my outpatient orthopedic colleagues, who are wonderful, but I'm just, by the nature of the diagnosis of the child that I serve. And also many of my clients are homebound for one reason or another, due to ventilation, decreased immunity, they don't have a car. Lots of reasons that they're homebound. They can't tolerate their wheelchair for more than 15 minutes without extreme pain due to spinal muscle atrophy or muscular dystrophy. So the transport isn't possible. I go see these children. I don't charge anything extra. That's unethical, but I go and write several letters of medical necessity for them to get the equipment that they truly need to live. I have patients that I go in and I work with a family to try to position them so that they don't choke at night and they stay oxygenated and they don't pull out their feeding tubes. And I'm there helping that health outcome and educating that family and writing those pro bono letters of medical necessity that usually take about an hour, and then they typically get denied. That's okay. I'm stubborn. I'll write it again. And so that's, this pro bono time to help these faces that I see. It's different when it's paper, but I will spend that time to do that. What's a challenge for me is I'm also a business owner. That's a hard hat to wear in the medical field. But I do have to make it make sense to do what I do and be away from my children. But I love what I do, and it means a lot to me and my colleagues. My question is, due to the cuts we've received starting April 1st, and then traditionally and statistically, there is a huge administrative overhead cost that increases with MCO implementation. And traditionally and statistically, there is a reduction in reimbursement. How can I keep providing that special niche of service to these kiddos and their families that they are profoundly disabled usually that we travel to? And how does it improve their health outcomes if I can't do it?
So I hate to make assumptions, but I'll assume that probably a lot of the individuals you just described will not be going to managed care. So your kiddos that are disabled and have Social Security or possibly on a waiver, they won't go to SoonerSelect, and so you would use the same process as you do today. For those that are not considered disabled yet, or like if you, I don't know if you have TEF for kids, for example, they won't go.
Right. Many of them do have TEFRA as a secondary.
Okay, so they won't go to SoonerSelect at all. So these, like you mentioned, the profoundly disabled, they'll stay in the current service delivery. That was Mr. Corbett mentioned earlier, that maybe within a few years, we're looking at transitioning the age blind disabled population. That's who that would be.
So, and I'm grateful that you're being more careful with this population. I agree with you completely. And if you would like any of our expertise in making any decisions, we like giving pro bono time, so we'll do it. My question is, for when that happens, these families are asking us. I'm in their living room. I'm sitting in the floor of their bedroom, waiting for the suction machine to turn off so they can hear me. How's this going to be better when it happens?
Mm-hmm.
When it happens, and I have to tell them. How do I tell them it will improve their health outcome?
So great questions. So I will say, as we go through that process, a couple of years from now, we will have, events like this where we can specifically talk around the special needs of this unique population, what that transition would look like. I mentioned earlier, we brought in national level consultants to help us with this. So we do the same thing with that and making sure that we didn't miss anything. I know we've all heard transition stories from other states as they transition this population that did not work out so well. Again, lessons learned. And so we definitely will want your voice. We'll have requests for information processes. I actually had a conversation with an individual walking in this morning about this specifically. So when that time comes, we'll definitely let you know. It sounds like you're already engaged, so you'll probably be on top of it. And we'll want your voice at the table then.
Dr. Luce, how will CDT codes, including oral surgery CDT procedure codes, be paid by dental plans?
Thank you for that question. So all CDT codes, that is C dental codes, will be reimbursed by the dental plans. All the codes that we currently cover, that is under Sooner Care, will be covered under the plans under SoonerSelect. For oral surgeons who do bill for CPT codes, just like they're paid by medical now, they'll be paid by medical when we switch over to MCO. So that means that oral surgeons may need to contract with both the dental plans and the medical plans.
Can Native Americans only choose a dental plan and not a medical plan?
They can.
If as a mental health provider, we choose to credential with all the MCOs, does this also mean we will be required to take adult clients who will now be included in the expansion?
Could you repeat the question?
If as a mental health provider, we choose to credential with all MCOs, does this also mean we will be required to take adult clients who will now be included in the expansion?
I see what they're saying. So it's sounding like this is currently a child only. It's sounding like this is currently a child only serving agency, and they're wondering if they would need to become an adult and child serving agency. And certainly not. You would have the opportunity, a greater opportunity to serve adults in the future because of the expansion in Oklahoma, but you wouldn't be required to serve adults as well.
And while we're on the topic of credentialing, I think I'm failed to state earlier, and there's been mention about administrative costs, for example, with having 4 plans. Although our plans are technically competitors, they're coming together and working to make sure that the process for our providers is as efficient as possible, because we all know without our clients getting served, without our provider network, no one succeeds, including our partners. And so they have worked together to create, we have the requirement of using a uniform credentialing application. And then we know that on top of that, some of the plans may have additional questions they want to ask that other plans don't. So they've actually chosen to come together on their own to create a supplemental uniform credentialing application supplement that is the same across all plans. And so once you fill out that application once, you have filled it out for all providers, and that's inclusive of the dental plans as well.
Good morning. My name is Lynn Means, and I'm the Executive Director of the Oklahoma Dental Association. So I'm here representing the 1,000 plus dental providers in Oklahoma. My first question, I have two. If MCOs improve health outcomes, how are 7 of the bottom 10 states in health nationally currently under managed care Medicaid, including the bottom 2, Louisiana and Mississippi, numbers 49 and 50?
Thank you, Lynn, for that question. As Traylor mentioned, we have had the ability to interview many of these states. Not all of them have been successful with parts of their Medicaid program. And some of those states are the ones you mentioned. It has nothing necessarily to do with the Medicaid managed care program. It's the conditions that they have in their state. Many of them are social determinant issues that are challenging. But we took all that into consideration for purposes of dividing our plan, which includes physical health, behavioral health, social determinants of health, as well as dental. So we feel like we've had the best opportunity to understand what has worked in other states, what has not worked in other states, and taking the opportunity to restrict ourselves to only the successes of those states and to remove all of the failures that they've had. So we've taken all the input we could for purposes of crafting what we think is going to be a very nice solution for Oklahoma.
My second question. The Healthcare Authority currently operates at about 4% overhead, while MCOs operate at an average of about 15% overhead. How can sending $2.2 billion of our tax money to middlemen, private insurance companies that operate at over 3 times more, save the state money while maintaining the same level of care, or better, as you claim, and the same number of providers who deliver that care? Please explain that math.
I'll try to help you with that. First of all, I think it's important to recognize that what we've entered into is about a $2 billion contract with all 7 plans. The vast majority of that money stays right here in Oklahoma because it's paid to providers. It's not paid out of state. A large percentage, about 90%. The administrative costs that our plans incur is for the coordination and management of care. We do a fantastic job at the Healthcare Authority. But quite frankly, we're not managers of care in the regard that we believe we need to be. Therefore, the cost of being able to manage care versus provide a fee-for-service business that we operate today has a greater administrative cost to it, but it has a high return that comes with it. When you talk about where we're actually accessing care, this is all about providing preventative and primary care. You could go through all of our claims data at the Healthcare Authority for the last several years and see where there were opportunities, had we had early intervention, had we had preventative services, that we could have changed the direction of someone's life and the cost associated with it. That's our plan today, is to actually utilize the current cost that we incur today and redistribute it in the most effective way possible for health outcomes, which has an efficiency gain to it that comes with it.
Secretary Corbett, I know as we've been in the pandemic, telehealth has been a huge asset to us. How will that continue? Sure.
Well, I think we would agree, and I think most states would agree, that telehealth in the past, prior to the pandemic, has been a thought, has been a consideration, but hadn't been a reality. Just to give you some context, the last 12 months of the year prior to the pandemic, I think our total usage of telehealth and telemedicine was something in the neighborhood of 10,000 visits. That's on 1 million people, 10,000 visits. During the pandemic, which we allowed that to be the case in response to the pandemic, which the provider community, the member community, and quite frankly, the citizens as a whole, I think embraced that tremendously. We've had close to 1.5 million visits that took place in the 12 months during the pandemic. We recognize it is actually a solution. What's interesting about it is that it was a talked about solution. It was never actioned until something like the pandemic gave rise to having to do it. I think we've now realized it's not a pandemic response. It is a health access response, and we need to continue to embrace it. And so certainly our plans are embracing of that. We're embracing of it at the state level. And there's been lots of movement with the feds to do the same thing. So I see that as a continuous solution to health access in Oklahoma.
Hi, good morning. My name is Heather. I am with an agency out of Durant, Oklahoma. We're a really small agency, very rural. We're a behavioral health agency. I've spoke with many behavioral health agencies that only bill Medicaid, and they have many concerns. So my first question though is, this is the first time I've heard it today. When you say disabled won't be transitioning over to the SoonerSelect, is that everybody that has qualified for SSI for mental health also?
Yes, so if you are disabled, declared by Social Security to be disabled due to a mental health issue, you fall in that ABD population and you are not transferred over into an MCO.
Changes a lot. Okay, so my next question, this is a lot of billing questions because I can't get answers from several places, and I've asked. I've been doing billing for the agency for almost 10 years. So my question is the H codes. Mental health is strictly just H code, H0034, things of that nature. When we transition to the SoonerSelect, most private insurances use the CPT codes. There are no CPT codes for rehab and case management. What will we do to bill those?
You'll have access to all the services that we cover today. So all the paraprofessional, peer recovery support, case management, in addition to licensure candidate services as well, which is not something that a lot of commercial lines pay for today, but that we required it within the RFP for them to do that. So we're working through what that'll actually look like. But my guess is that you'll still use the majority of the code set that you do today. It's up to the plans to figure out how to accommodate that.
But when are we going to know? I mean, we're only a few months out. We have to transition all the treatment plans, the codes in our systems over. How soon will that be?
So we're working with them. I mentioned the implementation work groups a while ago. We're working with them to talk that through. So one thing we did also as a state is require that, Commissioner Slatton-Hodges has brought the state forward in so many ways, but one of which is data collection. So you're familiar with like our customer data core, the car assessments, and that's what goes and builds the PA. We are still requiring that of our plans to utilize that because our providers know it and are used to it. And so that will be a piece of the PA process moving forward. We're working with the plans weekly, daily to make sure that they understand that and they're all asking the same questions in the same kind of way. We're working with them to possibly use a single portal. It may not happen immediately, but I don't know if you do direct billing into the portal or if you have an EDI vendor, but we're looking to see if we can use EDI vendors maybe to make it a little more seamless for providers so they're not having to bill into four different. But we're working through that. It's just part of implementation. And so my guess is within the next couple of months, we'll have a lot more definite guidance to give.
Okay, so I know we have to use third party, which is Availity and I believe Health Ally or something to build these for insurances. But I know a lot of agencies, behavioral health agencies that know of this, and it takes a process to bill Humana and Blue Cross Blue Shield. They don't even know where to start. So then that goes to my next question. CAQH is the credentialing that most of these are using, but it's mainly for medical providers. How will that be easier? How will you inform these agencies that they need to use this universal credentialing application, which is CAQH? Not many know that. So how are you going to put this information out there?
So we're working on that. And part of it's just going to be part of the technical assistance process that as you, so first I would ask if you have signed a contract with the plans. If not, I encourage all providers to sign contracts with the plans so you can begin that TA process with them. Because like you said, it's going to take a second. So for them to get they're in the process of hiring. We awarded these contracts on March the 1st. So they're hiring their Oklahoma-based teams, training their call center supports, and getting those boots on the ground to be able to answer all those questions. It's hard for us to say, give an answer that applies to all plans because they're going to be a little unique in how they approach various billing requirements. And so I'm going to continue just to say, talk to the plans, the folks at the table. They can probably give a lot more insight than we can. And we're just simply working through a lot of these implementation questions currently.
What I would say is the plans in the work group have, as we move forward, are very committed to try to make this as streamlined as possible. And what we would like to see at the end, double check it. What we'd like to see at the end ultimately is that instead of having 4 different processes, and I'm speaking for behavioral health here, and we have a separate behavioral health work group with the plans, instead of having 4 different, plus a process for your ABD, plus if you have a contract with the department, we would like all of that to be streamlined. And I truly believe that we'll be successful in that. We may not be successful on day one, but that is the goal. But I do think we'll be successful. Most of the assessment tools that are used, I think we'll be able to streamline across everybody. We'll have one that will be able to work well. I know they're doing a lot of work on the credentialing portal so that instead of submitting a lot of information to multiple plans can go in and get most of that information. And so I do think that our goal is the same as your goal, to streamline things as much as possible on the provider end, which then benefits all of us. Absolutely.
So then I have another question, and I bet you're going to say it's going to have to wait. So it is, as far as we have many limits as far as behavioral health. We can only see them for 2 hours a week, X amount of times during the month. You know, our case managers can only see them 45 minutes to an hour and a half. There's a lot of limits. There's the 35-hour rule where we can only bill 35 hours in a week. Is that going to still apply? A lot of those limits.
So, and Trailer can correct me if I'm wrong. Plans cannot go below what is currently set for a minimum baseline for every person. So when this was written, what currently exists is the baseline. Plans can go above that and shape what they want to do, but they cannot go below that.
Okay, so will the levels of care still exist? Like the level, for example, a level 3 with rehab or a level 2 without rehab?
Those are what we are discussing now. It seems to me like outpatient is viewed a little more flexibly on the side of the plans than even how we are currently structured. So I think you may see something, and again, I can't speak for all 4 plans, but I think you might see a little bit more liberal on the side of outpatient as a preventative measure to manage overall care.
Okay, so we are certified through the Department of Mental Health currently.
Yes.
Will those still required paperwork, all the documentation that they require be altered in any way with the new MCOs?
So I think what you're saying is that in your certification process, it dictates that certain things will happen. And you're saying, will we alter what is required in certification to meet the managed care plans?
Will they change in any way because the MCOs are so flexible?
So I think currently what exists. As we go along, if we see that there are things in those rules that are overly burdensome, then yeah, we would want to adjust them based upon any kind of new flexibility that may exist. But there's always going to be this is the benchmark for good care. But absolutely, if those are in any way causing additional burden, then we would want to look at that. Now, keep in mind, if you're a mental health agency, you can receive Department of Mental Health certification, or you can receive national certification and have that choice.
Okay, so this is my last question, and this is directly for behavioral health. So you say I keep hearing like this is a trial run, that these providers these insurance agencies or whatever you want to call them, have to report. So this seems to me like this is some sort of a trial run. Will they lose their contract if they are not providing proper funding, or I'm sorry, my words are not coming to me. They aren't following the guidelines set in their contracts?
So since that actually applies to a really large overall question, I'm going to let Kevin address that if he likes, about what consequences are for not following it.
Yeah, I'll be happy to take that. I mean, one of the things that we did and spent a lot of time on is crafting our contract to understand what the requirements are, the expectations, and the compliance requirements with regards to that. So there's a lot of requirements in our contract, and the consequences of not meeting those requirements could rise to a level of a termination of a contract. We would hope that that never comes to that case. We're going to be monitoring this on a daily basis and know kind of where things are moving towards and have the ability to take corrective action. I know the plans are committed to success on this as well. They recognize the requirements in the contract. They recognize the penalties that we put in for lack of compliance. They also understand the terminations that are there. Those are all things that you would expect to be in a contract. You know, the execution of this is on us to ensure that they're going to be successful and we're going to be successful as well.
And this isn't a trial run.
And this is, yeah, to be clear, this is not a trial run.
This is for Dr. Luce. I work for a dental office in Bristow, Oklahoma. It's a very small little town. Our concerns are we have somebody that takes care of our Sooner Care, filing the claims, checking eligibility. We have one portal, and we love that we just go to one portal. We find out whether this person's eligible or not before we provide our services. Is that going to be something similar now that we have 3 agencies that we're going to have to go through? Are we going to have to check all 3, or will there be one place for us to go for eligibility?
Trailer, you probably can answer that better.
Sure. So they will have 3 different portals. And so that's what's part of the technical assistance that will be provided by the plans, is to training you on their specific portals. Just a reminder, the Healthcare Authority will retain eligibility determinations and processing. So that will still be a function of the Healthcare Authority, but you'll be able to check their eligibility within their providers, the managed care partners individual portal, but you'll have.
So she'll still be able to go to the Sooner Care portal and see if they're eligible? No.
You can.
She'll go to DentaQuest or.
You will still have access. So let's assume you have an American Indian individual in your case panel that chooses not to be in SoonerSelect. You'll still bill through the Healthcare Authority. So you'll have access to the provider portal there, be able to check eligibility there, in addition to the 3, if you choose to contract with all 3 plans.
So if we have prior authorizations that we need to file, we're filing them with the individual DentaQuest and Liberty and.
That's correct. Okay. And the member will each have a card. Their card will reflect the plan that they belong to instead of a Sooner Care card that they have today.
Will all 3 be doing electronic deposit, or will it be checks? Have
yes, electronic.
It'll be all electronic. Okay. So you were talking about the credentialing applications. I have 3 doctors, so I'm going to have to do 3. You're saying that there will just be 1.
You'll have a uniform application.
Okay.
And then once you complete that for each of your doctors, that'll be the same information you submit to each of the plans. So the process is you'll still come through the Healthcare Authority as the front door, and then go through all the current screenings you do with us, the renewals with us. From that pool of providers, each of our plans will pull from that. And so once they contract with you, then you'll have that uniform credentialing application along with 1 supplemental that's the same among all the plans. And then once you complete that, that's what you'll submit. So you won't have to submit a different form for each.
What about fee schedules? Are all 3 Liberty and DentaQuest, will they all have the same fee schedules that?
They may vary a little because they may offer some of the services we don't offer. Typically in the industry, those are proprietary to each of the partners. And so they won't say publicly what their exact fee schedule is, although I'm expecting it to be very close, if not the same as to what we provide today. But those are great questions when they reach out to contract. Definitely have conversations around reimbursement, what their fee schedule looks like as you have those negotiations.
Okay. All right. Thank you.
Sure.
Is this on? Okay, hi, my name is Kaylee Kelly, and I work for a rural behavioral health outpatient clinic down in Wynnewood. And I've been doing billing and payroll and all of that for about 21 years now. And so this is quite an adjustment. You said that there's going to be a universal credentialing, and I'm assuming you're referring to CAQH, right?
Well, the uniform credentialing application is actually created by the health department.
Do you have it? Because we don't have access. We go to all of these providers and there's a credentialing process for all of them. CAQH actually only services United Healthcare and Centene. So Blue Cross Blue Shield of Oklahoma and Oklahoma, whichever one's Centene. Centene is where you go through. Yeah, one of them. So if we do that, we're trying to tell our people to get credentialed through CAQH. But if it's only going to work with 2 of them, where's the universal one? Because We don't know where that is.
It's a state universal one, so we can get that to you.
We
We've
do.
recently finalized the supplemental piece. That's the same across all the plans.
Okay.
And so it's possible that their contracting agents, which remember, a lot of their contracting agents may still be national because they're building their Oklahoma presence.
They are national, so they don't have a clue.
Right. And we're working with them on, we're doing secret shopper calls. All the CEOs are getting texts from me on a daily basis telling them to improve the customer experience.
Okay.
But we will get those to you shortly.
So we are in the process because I was told by Oklahoma Healthcare Authority, the two people that I did talk to in provider enrollment are no longer with you as of apparently last week. But for 6 weeks, I was told that there was going to be, basically we were going to be like a rental property where we have a contract with you and you sold us to another company and you were sending all of our information to those agencies. So we haven't done any of it. So we're starting now and our people are, of course, panicked because I have 50 clinicians that work with us. So we're trying to get them with their professional liability insurance. We're trying to get them with the CAQH, all of which are very lengthy processes. So how do you recommend, if you've got this universal, we feel like we're behind, but we're still waiting for this universal credentialing thing.
So don't panic.
Okay, because I am.
Don't panic. It'll be fine. So we will pull you along this process. I promise. We can't serve our members without you. And so we're not going to let you be out there on your own, trying to figure this out on your own. So I would say, take a breath. We'll get you the uniform credentialing application. You have to remember they're trying to build their network. And so they're ahead, but then some of these things are changing daily. So we're going to we'll work with our partners to make sure that experience is streamlined for you.
And you mentioned that, do you have a contract already? We can't really get a contract already without having all of these people ready to go with us. So we can't get a contract with, say, Blue Cross Blue Shield without having all of the information about our clinicians. So we are literally paused until we either get that universal or we individually do every bit of this credentialing. So
sure. I would say having the conversations with the plan is the very best first step. So have the conversation, sign letters of intent, for example, start engaging with discussions around reimbursement and what credentialing looks like, and then allow them to pull you through that process with our help.
and we're going to have a local person in Oklahoma, not someone in California who can actually answer for me.
It's a requirement. And so they are building that out currently. You just remember we're a little over a month into this. And so they're in the process of hiring. In addition to the implementation work groups, Melody and I meet with the plan administrators weekly to talk through issues, specifically focusing on provider adequate networks, as well as issues like you're talking about, so we can quickly fix those and address them. Also, a big thing we're focusing on is their Oklahoma staffing presence. So we make sure weekly we want to see percent changed and people hired, key staff, call center staff. What does that look like? So we're diligent and laser focused on those areas.
Okay, and then my next thing is a billing, because this affects me directly as it does Heather. I think we both use Think Health as our processing. Are we going to literally have to go into each of these and do our billing and go back old school where we're having to submit individual claims versus batching?
So we actually are working in the implementation process to try to figure out a way to where Think Health can do that work for you, to where you're entering into Think Health and they connect with the MCOs, but that's in process. So we still have to work out those details.
Okay, perfect. Thank you.
Melissa,
Hi.
I think you have one over there too.
Sorry. Oh, sorry. Hi, my name is Stephanie. I'm the owner of Therapy Link Solutions. We're a pediatric therapy center located here in the Oklahoma City metro area. I contacted, we credentialed with Blue Cross and Blue Shield independently with my therapist. And so we've been through that process before, even with an individual contract with Blue Cross and Blue Shield. That sometimes takes 2 to 3 months per therapist. And so when I contacted United Healthcare and Humana, the individual that I spoke to, she was really excited because I was the first person that she had spoken to. And so I asked her to walk me through the web access to do the application. The links did not work. She gave me a particular email address for me to reach out and was very kind, gave me all the information I needed to notify them. I received an email back saying, your request has been received by Humana Healthy Horizons. Requests are completed in the order in which they are received. This was early last week, so okay. When I went to United Healthcare, spoke to the individual, They too walked me through United Healthcare outsources speech OT and PT to a secondary company called Optum Healthcare Solutions. They sent me a link to begin the very lengthy online application. It is not a quick anything. And at the end of it, it says, please note the entire credentialing process may take up to 5 months. Is this October 1st a hard start date for you all? Is there any flexibility in this? If it takes up to 5 months for the entire state of Oklahoma, for every pediatric therapy center, how realistic are we about that October 1st start date?
October 1st is very realistic. And we expect all of our partners to get their providers on board and do what they can to make those processes more efficient and quicker. What would keep us from moving forward October 1st is if we don't have our federal approval through CMS for either the waiver or any of the contracts or the rates that we're paying to our partners. We have set September 1st as kind of a go, no go for that. So if we don't have federal approval, we'll hit pause and more than likely take our hand off pause January of 22. Another thing to think about in the September date is if an individual plan is not ready, for example, if they don't have an adequate network, if they just are not ready to move forward October 1, we'll have options in dealing with that individual plan at that point, whether or not we allow everyone else to move forward and hold them back until the next open enrollment, for example. Again, all your comments I hear and we're hearing as we secret shop our partners. It may have been the first call the Humana representative received. Their local presence, I believe, started last week. And so they, before then, were sending to national contracting agents. And so I'm actually excited to hear they have local presence that's learning and was very friendly with you. So to me, that's a positive. I've also reiterated with them on many times, you only get an opportunity to make one first impression. And it sounds like a lot of the first impressions have not been great. And I hate that for everyone involved in it. But we are working with them on continuous quality improvement as we go through that process. They're all in the room. Again, I would encourage you to stop by and talk to the Humana folks and the United folks about how Optum has communicated so far as well.
Are without coverage, without services, without all of the necessary things that they need to live a productive life. If we're waiting for months for our company to be approved by these companies, the children wait.
So we would never allow that. I mean, that's why we come to work every day, and these things keep us up at night as well. We would never allow a kid to go without service because of a transitional issue. That would be something that we would handle internally, whether it be continue to pay you directly while the plan gets ready. That transition, I've yet to be involved in a large scale project where we don't have bumps, but at the very minimum, what will ensure is continuity of care and that members receive service and that you receive payment timely. So we'll work through all this other stuff. It's stuff to be anxious about for sure, but we'll make sure the members receive service and you get reimbursed for that one way or the other.
Before I take a question over here, I do have one virtual question to ask of you. When will the fee schedules for each of the MCOs be available, and will they be included in the benefit comparison guide?
So I'll tie back to what I mentioned a while ago. They're proprietary, so they will not be published, but they will be in your individual contracting packets that the plans submit to you on an individual basis. Talk to the plan. I would talk to the plans. That's all. We don't manage their fee schedules. They're proprietary and belong to their companies.
Good morning. My name is Portia Richardson. I am a primary healthcare provider at Uptown Medical Center. I'm a nurse practitioner, and I have 2 questions. My first question is a group of patients that I just haven't heard anyone talk about, and that is the OEPIC or Insure Oklahoma population. What happens to that program? Does it disappear? Are we forgetting about it? Do we just throw them under the rug? What's that look like?
Great question. And no, we've not forgotten about we love the Insure Oklahoma, and it's provided coverage to so many Oklahomans. And great question. That's actually part of the expansion. So we have, if you're familiar with IO, or OEPIC back in the day, we have the individual plan, which is individuals that meet certain criteria up to 100% of the federal poverty limit. That's their income. And then we have the employer-sponsored insurance plan, which is where we subsidize premiums and the cost of insurance for certain qualifying small businesses. And then they purchase from the private market for their employees. And that goes up to 185%. And so the individual plan is up to 100%. That automatically qualifies you for expansion. Expansion is actually a more robust benefit with no cost sharing included, or no premiums required, excuse me. So those individuals will receive letters that they are transitioning to the expansion plan July 1st. And so Intra-Oklahoma IP will phase out, but to the benefit of the members, they'll continue to have coverage. Intra-Oklahoma, as I said, goes up, employer-sponsored goes up to 185. Expansion goes up to 138. So those individuals from 139 to 185 will maintain coverage through their employer-sponsored insurance plan and will continue to be subsidized by the healthcare authority. So no one in this transition loses coverage.
Perfect. And then my last question is in regards to the payments. It's a special type of payment that we receive as a primary medical home for patients. I mean, it's a small amount, but when we're switching over to Blue Cross Blue Shield, Humana, how does that now, we get those payments? How does that look? Is that something that we will understand to be rolled in to a price, or is there already a set schedule for those payments? Thank you. Coordination, that's what it is.
So I think Traylor's mentioned a couple times that the fee schedules and there's some flexibility in how plans will pay. Fee schedules are proprietary. The dollars for the care management fee, which I believe you're referring to, that's the $5-ish per member per month payment, they are in the capitation rate. So those dollars can be used to fund whatever rates that are determined to be payable for fee for service or value based. Those dollars are there and available.
We want to thank you for your questions today. Before we take our last question, I do want to encourage you to meet with our MCO partners as well as our panelists today. If you have a question that you did not get answered, you can either bring that to me and in your contact information, I will make sure it gets answered for you. We also have a form online at oklahoma.gov/OHCA. That just changed, so I'm trying to remember it. And you can fill out that form with your question and we will get that answer back to you as well.
I'm a licensed professional counselor and I appreciate all the information about behavioral health, but I'm also a board certified behavior analyst. And I want to thank you for covering ABA services for our clients. How does this all affect them?
I'm sorry, Commissioner was distracting me with a question over my side. Could you repeat the question? I heard ABA, so we're talking about ABA services and population.
So our clients are authorized through a completely different route from behavioral health.
Right.
Are they still going to have to choose unless they're on Social Security? See, I'm so confused.
Right.
If they receive Social Security, nothing changes.
Right, and they'll still have a Sooner Care card. So
Okay.
it'll look just like the same, but let's say if they have it, if they go to a plan, then they'll have a card that is representative of that plan. I'll also say, since you brought up ABA, that reminds me, we haven't talked about the Children's Specialty Plan yet. And so a lot of our ABA clients I know are in the custody of the state through child welfare. And so we actually have one plan through Oklahoma Complete Health that will serve those clients specifically on a statewide basis. So if a kid comes into custody, they're going to have an intensive screening done, medical, physical, behavioral health, everything that needs to be addressed. And then they'll have a single care coordinator at the Oklahoma Complete Health Plan that will manage their care statewide, no matter if they're in Guyman one day and then move to Ardmore the next. They'll transition their care for them. But going back to ABA, that's an important service that we are actually looking to expand as well at the Healthcare Authority, because we see its importance, especially an additional medical necessity criteria than we currently look at today. And so we see that as improving health outcomes currently, and it's a great modality for certain populations, and we would expect that our plans would as well. And if we expand at the Healthcare Authority through rulemaking and otherwise, that will carry on to our plan partners as well.
Okay, and the three of us are BCBA, so I assume we need to all have a contract, but do all of my registered behavioral technicians also have to have a contract?
If you have a rendering contract with the Healthcare Authority today, you will be credentialed through a plan.
Okay, that's the signal. Again, thanks for taking the time to be here today. Your input is very valuable. I've said it many times, is that we're very fortunate to serve the Medicaid population that we serve, but quite frankly, we don't deliver care. We facilitate care. Our partners are going to facilitate that with us, but it's the 70,000 providers we have across the state are the most vital to what we're doing. So we would hope that you would take the time to, again, give us your questions, your concerns, but also visit with our partners who are going to be with us in this venture and get your questions answered by them as well, and continue to follow us. We're going to have future town halls in the next coming months. And so all these questions will be captured, they'll be posted and be answered, hopefully to your satisfaction. So, but thank you for taking your time today. Again, visit our website for any questions that we might not have gotten to today and the answers that we're going to provide. So thank you again and enjoy the rest of the week.